All right, I'm going to start things off. My section of the talk is going to give you an overview about the basics about juvenile myositis, and then I'll hand it over to Dr. Wahezi, who's going to talk about treatment and future implications. So this is the outline of what I'm going to talk about, and we'll just go through section by section. The first is, what is juvenile myositis? So when you just look at the word, you can kind of break it down into its component parts, and you'll have an explanation of what the disease is. So for dermatomyositis is the most common form of juvenile myositis, and that's mostly what we will be talking about today. So that word, dermato, means skin, myos is the root for muscle, and itis means inflammation. When patients have muscle disease without skin disease, it is called juvenile polymyositis, and poly means many muscles involved. And the various types of juvenile myositis are all autoimmune in nature. This is to remind us that the skin is a window into the blood vessels, and blood vessels are affected in myositis. So to start at a basic level, here's a picture of a blood vessel with the cellular and the liquid components of blood. So you'll see the little cells of the blood going through the blood vessel. And white blood cells here are the players that make the inflammation. So here's a detailed diagram of the different types of white blood cells that will be a test at the end of the lecture today about these. Just kidding. These cells are basically what make inflammation. So inflammation is when immune system cells, the chemicals they produce, and the antibodies that some of them produce attack blood vessels and tissues. You might see some of these words describing the different types of white blood cells in your child's blood test results. But inflammation comes from these immune system cells becoming activated. This normally happens when we get an infection, and that's the healthy component of the immune system, these white blood cells that will, and antibodies that will attack germs. But in the case of autoimmune disease, there's inappropriate activation and the immune system attacks the body. One of the structures that gets attacked in juvenile myositis are the blood vessels. So here we have an artery. So blood comes from the heart, it goes into arteries. Arteries get smaller and smaller and then turn into capillaries, which then turn into veins, and then the blood goes back into the heart and the lungs. So what we're interested in myositis are these teeny tiny capillaries. The inflammation affects the walls of the endothelial cells, which is the wall in the walls of these tiny capillaries. And we call this vasculopathy. So here is a cross-section of skin. And as you'll see, there's blood vessels here that feed the skin, and they come up to the very surface where they make this nice little U-turn right at the surface of the skin. And this is the area, these little tiny capillaries that get inflamed from the system. And that causes rash on the skin. One of the places that we can actually see these teeny tiny blood vessels as they make their way to the surface of the skin is at the nail fold. So this is where your skin meets your fingernail right at the cuticle. So your child's clinician might use a magnifying light to look right at that skin at the edge here. And normally we see these nice little loops that come right up to the surface of the cuticle. But in myositis, the dermatomyositis in particular, the capillaries get inflamed, irregular, irritated, and so you start to see that they get dilated, and then they can even drop away. And that's a sign that there is vasculopathy going on within the blood vessels. And even in some kids, if you just look with the naked eye, you can see those dilated vessels there. And you can also see some overgrowth of the cuticles in patients with dermatomyositis. One of the characteristic rashes that comes from these inflamed blood vessels affecting the skin is called Gottron papules. So these are papules, which means bumps on the surface of the skin, generally at places where you bend. So the fingers are the most common place to have Gottron papules. And there's a variety of appearances that Gottron's papules can take. And some patients don't have actual bumps, they just have redness at the knuckles, and we call that Gottron's sign. Other common rashes in dermatomyositis include rashes over the joints, like the elbows and the knees, and then facial rashes. Sometimes we call it a malar rash that looks similar to a lupus rash that covers this area of the skin here. And then the eyelids also can get red or even a purplish color, and that's called the heliotrope rash. It's named after a purple flower. Patients can get rashes on their necks, their chest, their back. This is over the patient's back, which is called a shawl sign, and this patient has some areas of ulceration where the skin is kind of broken open. And this little boy has a heliotrope rash around his eyes, but he also has facial swelling that you can see when you look back at a picture of him previously. So some patients can develop swelling of the skin. So that's the dermato part. Now the myo part, the muscle. So muscles are affected because blood vessels that feed the muscles get inflamed and irritated, and they let out white blood cells that then attack the fibers of the muscle. So in polymyositis and dermatomyositis, it affects what we call proximal muscles, meaning these are closer to the center of the body, like the neck, the abs, the shoulders, and the thighs. A biopsy of the muscle and look under a microscope, we see healthy muscle here on this side, and then we see affected muscle over here. And basically what we see is that the muscle fibers normally have nice even sizes. And here you can see that there's some muscle fibers that are small and others that are large. So we get atrophy in some of the muscle fibers. And then you also see infiltrates, meaning like places where white blood cells have left the blood vessels around the blood vessels. So this is the wall of a little tiny blood vessel, and all of these dark cells are white blood cells that have left the vascular system and are attacking in the muscles. So who gets myositis? And these numbers here refer to juvenile dermatomyositis because it is the most common type of myositis in kids. 85% of kids with myositis have JDM. So approximately 4 children per million are diagnosed each year in the United States. And CureJM suspects that at least 4,000 kids in the US have JDM. It's more common in female children compared to males, about 1.5 to 2.5 times more common in girls. And the median or average kind of age at onset is about 7 years of age, but 25% of kids are diagnosed below the age of 4. And from the studies that we have looking at racial and ethnic background, non-Hispanic white patients are affected more commonly than Hispanics, African Americans, and then Asian Pacific Islander. How do patients present? Meaning, how does JDM affect them when they first seek care? So this is a table from our rheumatology textbook in Pediatrics. So the first is constitutional symptoms. These are things that affect the whole body, like fatigue, which is very, very common. Fever and weight loss happen in about half of patients, and swollen lymph nodes is more rare. Then muscle weakness is seen in almost all patients with juvenile myositis, and it can be anywhere between mild and severe. A good number of patients get muscle pain or tenderness, and about half of patients present with arthritis or inflammation in the spaces of joints. Then thinking about how it affects the skin, we talked about heliotrope and Gottron's papules being the most common. Photosensitivity means that the skin is sensitive to the sun, and the sun will bring out a rash. We saw examples of the malar rash on the cheeks and the nail furrow changes in the shawl sign. Raynaud's phenomenon is a condition where the skin of the hands changes colors and becomes painful when the patient is exposed to cold. Ulcerations mean that the skin can break open in certain patients. And then calcinosis is a unique phenomenon where calcium leaks out into the skin, and it can form like nodules, like bumps. This is often much more common later in the course of disease, so it's unusual for patients to present with calcinosis. And then finally, lipodystrophy is loss of fat, and that's seen more in the face and the arms and the legs, but that's also a very rare presentation. The heart and lungs can also be involved in patients at presentation and then later in time. Fortunately, it's not exceedingly common. And then the gastrointestinal tract, so your stomach, your intestines, can be affected. Dysphagia means difficulty swallowing, and dysphonia means trouble with the voice, and that is due to weakness of the neck and swallowing muscles. And then other symptoms such as abdominal pain and constipation can also be present. So we'll now move on to why this happens. So dermatomyositis, juvenile myositis, is an autoimmune reaction in genetically susceptible individuals that is triggered by environmental factors. You can remember that sentence. I'll show it to you again at the end. That kind of breaks down why this happens, and it's certainly very, very complicated. There are different changes in various genes that can increase a patient's risk of developing an autoimmune disease. So you can think of genes as the pathways to tell the immune system to turn on or turn off. And genes are inherited from either parent, or they can be a new mutation when an embryo is formed. Environmental factors that affect myositis include sun or ultraviolet light exposure, because they activate immune cells in the skin and cause damage to the skin. And so those immune cells get activated to start fighting the damage. And then infections from various germs, not one certain infection, have also been thought to be a stimulus that could trigger a reaction of dermatomyositis in a patient who is susceptible to it. We know that patients with myositis have hyperactivity of the immune system. So some of those pathways that cause the immune system to turn on, like the accelerators, are actually working too hard. And maybe some of the genes and pathways that are brakes that tell the immune system to slow down aren't working well. And there's especially a chemical pathway called type 1 interferon that we think is overabundant or too active in patients with juvenile myositis. And then finally, there is a theory that when moms are carrying a fetus, maternal cells can go through the placenta and set up shop in the baby. And they found that when they look at patients with juvenile myositis, there is a high rate of this which is called chimerism, maternal chimerism, compared to unaffected siblings. So now that we know what JM is, how do doctors diagnose it? The criteria for diagnosis were actually first published in 1975, and in many ways continue to apply today, although we've gotten fancier over time. These are the 5 main features of the disease. Definite diagnosis of dermatomyositis requires one of the rashes, at least, heliotrope or Gottron's papules, plus 3 of the other findings here. And a possible diagnosis or probable diagnosis requires a rash plus 2 of the following. So we've talked about the symmetric proximal muscle weakness. And then moving forward, we'll talk a little bit about muscle enzymes, chemicals in the blood, and then 2 other ways to look at muscle to decide if it's affected, called an EMG or doing a muscle biopsy. So muscle enzymes are proteins that help with biological reactions such as energy metabolism. And the ending of the word ACE means enzyme. Enzymes are secreted from the blood into tissues such as muscle, into the blood from the tissues. So when muscle is inflamed, it secretes extra chemicals, these enzymes, into the blood. So these are ones that you will probably become familiar with as you learn about your child's lab results. Creatine kinase or creatine phosphokinase, CK or CPK, is only produced in muscle. And then these other 4 are produced in the liver as well as in muscle. And LDH is also produced in blood cells. Of these muscle enzymes, only a proportion might be elevated at diagnosis. So there was one study where they looked at 84 patients with a new onset of JDM, and the CK was elevated only in half. And you'll see AST, ALT, and LDH were also not elevated in every patient. 38 of the 84 patients had at least 3 enzymes elevated, but 7 of the patients had no enzymes elevated at all. And this is a common mistake that some clinicians can make because they think that for muscles to be inflamed, you have to have elevation in these enzymes. That's not always the case. There are other blood tests that we use to help determine the activity of the immune system, and they can include these tests here. So neopterin is a chemical that's released from activated white blood cells when interferon is upregulated or overactive. We also have chemicals called von Willebrand factor antigen. We look at different inflammatory cells, and then we can look at antibodies that are produced in patients who have myositis. These antibodies target parts of cells in the muscles, blood vessels, and skin and can cause damage. And then we also do tests to rule out other diseases, looking for other autoimmune conditions, other muscle problems that are not autoimmune in nature, and problems with the immune system. Okay, so this slide is a diagram that shows the various antibodies that are associated with myositis and some of the symptoms that go along with those antibodies. So the most common ones in kids are TIF1 gamma, which is also known as P150-140, and NXP2 antibodies, also known as MJ antibodies. So these are present in about 20 to 30% each of patients with juvenile dermatomyositis. It's really important to know that in adults with dermatomyositis who have these antibodies, there is a likelihood that the adult might have an underlying malignancy, but this is not the case with children. And we do not think that kids who have juvenile dermatomyositis are at a much higher risk for malignancy later in life. So don't let those antibodies scare you. And you'll see that the MJ antibody is more associated with calcinosis, that skin complication. Another common antibody in kids is called MDA5, in which patients can develop lung disease and also have skin disease. MI2 antibodies are also fairly common in kids. Most of these other ones are quite rare in kids, so I won't talk about them, but it's also important to know that myositis antibodies will be tested in almost most centers test for myositis antibodies, but up to 40 to 60% of patients may have no identified antibodies. Now we'll talk about electromyograms, or an EMG. So this can be done to diagnose inflammation in muscle cells, and it's basically done by a neurologist who puts a tiny needle into a muscle and then looks at the electrical signals. And there are these 3 changes that are seen in inflamed muscle cells. The pros of doing an EMG is that it can give us additional information about inflammation. It can be repeated over time, and it's inexpensive. But the cons are that the needle can be painful and scary. Even though it's a tiny needle, it can be a little scary for kids. And kids might not cooperate well, and you really need someone who's trained and has good expertise in doing EMGs. Another way that we diagnose is by taking samples of tissue. So that would be a muscle or a skin biopsy. The skin can be biopsied using this punching tool that takes a little piece of skin and then stitches are left in the skin. And this is what a biopsy of skin looks like underneath the microscope. Muscle can be biopsied by 2 ways, either using a needle when the patient is under anesthesia. A needle can be placed in the thigh muscle where it's affected and take a little piece of muscle out. Or a biopsy can be done by an incision, or a surgeon will put a cut in the skin and clamp a little piece of muscle and tie it off with a suture. And then we've already seen pictures of what that looks like under a microscope. Muscle biopsies are important, but they're not used in every center. Some centers perform biopsies in all patients with juvenile myositis, and others only when there's a question about the diagnosis. So newer techniques and stains might give us more information about the prognosis of a patient, meaning what will happen to them in the future. The pros of a biopsy is that it confirms a diagnosis, and it might predict some future manifestations of disease, and it helps us to rule out other diagnoses. The cons is that it is a surgery and it causes a scar, and the patient can have some pain when healing. Needle biopsies are less painful, and they're a minor procedure, but might not give us adequate information, so most people do open biopsies. And then another way we can look at the muscles to see if they're inflamed is by using an MRI machine, which basically uses magnets to release energy from atoms in the tissues. And here are some pictures of what MRIs look like. So water is white under certain sequences of an MRI. And so inflammation in a muscle means there's increased water. You've got more blood cells coming in and infiltrating the tissues. So you can see muscles are generally nice and gray, and you can see patchy areas where the muscles are more white, and that indicates inflammation. This patient has inflammation along the side there. This is a cross-sectional view. And this patient has some inflammation around the lining of the muscles as well. So the pros of an MRI is that it's not invasive and can be repeated, and you see a lot of the muscle. It helps to document a site for the biopsy, and it documents that the muscle is inflamed. But it can be expensive, and you might have to wait to get an MRI. For some kids, it can be scary. We can sedate young children so they stay still in the machine. It can also have false positives, meaning the inflammation might be there, but it might not be dermatomyositis. And it can even have false negatives, so muscles can be inflamed without the MRI really looking abnormal. So we'll talk now about how serious dermatomyositis or myositis can be. And it really is a spectrum of disease severity. So 2 questions to ask are, how severe are the patient's skin and muscle disease? And what other organs are affected and how severely? So there are some patients who have little to no muscle disease. We might call these amyopathic or hypomyopathic disease, meaning that more skin is involved more than muscle. And some patients have very mild skin disease. Kind of in the middle of the spectrum, patients have mild to medium severity of skin or muscle disease and might have a little bit of organ involvement. And then unfortunately, there are some patients who have very severe disease. They become exceptionally weak because their muscles are damaged. They might even need to be put on a ventilator because they're so weak that they can't breathe well. They can have involvement of their GI tract, severe skin ulcerations, lung disease where the lung tissue gets thickened, and they can be sick with infections. Dr. Wahezi will talk a little bit about the course of disease, but basically what happens is a patient's disease is active, and then with treatment becomes inactive. And after it's inactive over a period of time and medications are removed, then we call it remission. And at any time, if a patient relapses or flares, they go back into active disease. So about 30% of patients have a monocyclic course, meaning they get one episode of disease and then they go into remission without relapse. Up to 30% have a polycyclic course with more than one remission and relapse. And 30 to 60% have a chronic course, meaning it's ongoing active disease without remission despite treatment. The mean time to remission is about 4.5 years, and the musculoskeletal involvement tends to improve faster than skin. Myositis, fortunately, is rarely fatal nowadays. 5% is the quoted statistic. Before we used steroids for treatment, it was up to 30%. And things that can make a patient's disease course worse is if they have a delay in diagnosis or treatment, or if they do not adhere to the treatment plan. Complications that we talked about in some of those patients who are more severely ill include infections from immunosuppression. And if the skin is ulcerated, that's another reason that skin can get infected. The calcinosis cutis, which are these lumps or sheets of calcium in skin and tissues, and this loss of fat over the face. And we can't stress enough the psychological distress that patients can have over regarding having a chronic illness. So who is your treatment and care team? Now that we know what JM is, why it happens, how we diagnose this, and how serious it is, we move on to how you get help for it. And Dr. Wahezi is going to cover the majority of this. This is from a book called Myositis in You that's available on Amazon. It is like the Bible about juvenile myositis and really has a lot of wonderful information. And what we talk about is that the patient is at the center of this wheel of care, surrounded first by their family and then by teams of people who help. So doctors, therapists, people at school, mental health providers, and the patient's general pediatrician. I'm not going to read through everything, and you can look at this later on the video, but I just kind of, you can see here in Technicolor all of the interactions that patients' families encounter when JM becomes a part of their lives. And you also see that these providers must all communicate with each other and the patient and family so the patient receives the best possible care. So how do you get support? There is so much support available on the CureJM website. It's truly amazing. And some of the things that Jim talked about, like the information about what to bring to a medical appointment, how to organize your medical records, how to talk to the school about your child's illness, is all spelled out on the website. So please peruse the website in detail if you haven't already. There's also the Myositis and You book that's available as an electronic book or a print copy. And then it's really important that we provide psychosocial support for not only the child, but also the family to adjust to the physical impairment that happens, altered appearance, and the diagnosis of a chronic illness. Finally, there's a lot of support available through social media, through the CureJM Foundation, and also through the Myositis Association. So that is all that I have. Back at our outline, these are all the things that we covered. So juvenile myositis is an autoimmune disease that affects the skin, muscle, and blood vessels and organs and creates vasculopathy. It's an autoimmune reaction in genetically susceptible individuals triggered by environmental factors. It's diagnosed by blood tests, EMG, MRI, and biopsies. And it can range in severity from mild to moderate to severe. It's rare to have severe juvenile myositis. And just remembering that you have a huge rainbow of people on your treatment and care team, and that you can get support from CureJM and other families. So now I'm going to stop sharing my screen. I'll turn it over to Dr. Wahezi. She's going to cover treatments and impacts on daily life.
Okay, you can see my slides?
Yeah.
Okay. Well, thank you, Dr. Curran, for a great introduction, and thank you again to CureJM for having us. We certainly know how hard it is when your child is diagnosed with a new disease, and certainly how difficult it is to sort of navigating the waters and kind of predicting what comes next. And so we're happy to be here to try to help walk you through it. I'm also going to emphasize the Myositis in You book because we do, it is such an amazing resource. If you haven't heard about it or you don't have it already, it really walks through everything that we're talking about and way more, just to give you sort of the overview of everything that you could possibly expect related to juvenile myositis. So I would definitely look into that. My portion of the talk is going to go over just basics about treatment goals, what you can expect from treatment, and just sort of the impact from the treatment on your lives and your child's lives. Again, this is sort of just a basic overview. We didn't want to get too into the nitty gritty. As Jim mentioned, there will be a series of webinars, so perhaps there might be another one on treatment, and certainly you can talk to your doctor about if you have more questions. So first I wanted to start off about the goals of treatment. So Dr. Curran mentioned about inflammation and the immune system and how that is really a key factor in what causes juvenile myositis. And so really one of the primary goals of treatment is to control that inflammation. And in doing so, we hope to improve the fatigue that your child might be having, to decrease any pain or discomfort that they have, improve their muscle strength, function, improve any skin rashes. And while we're doing that, we also want to prevent long-term complications. So it may seem like their disease is getting better, but yet the treatment continues. And the reason for that is we really want to eliminate all evidence of disease activity because we don't want them to get things like that calcinosis and lipodystrophy. We don't want them to get muscle damage or skin damage or things that can't be reversed. So that's always an important factor in our treatment. While we're treating, we want to try to minimize side effects. So that certainly plays into the conversations. And as Dr. Curran mentioned, we really want to support their emotional health. And in doing all of these things, we hope to really improve their well-being and really get them back to their daily lives. So we talked a little bit about how JM is an autoimmune disease and how the immune system is really confused and it's attacking your child's body, whereas normally the immune system would fight off an infection. Here it's attacking. You heard the blood vessels, the skin, the muscle, and so we want to lower that immune response. But the immune system is really this delicate balance. So if we lower the immune response too much, then perhaps there's an increased risk of infection. And so the treatment really is finding that delicate balance where you're really quieting the immune response so that your child can recover, but being cautious in doing so that they're not at too high risk of infection. But you'll hear us sort of discuss that a lot when it comes to the treatments. How much treatment do we give? And it really depends on the severity of the child's manifestation. So you heard that there really is a spectrum of disease. So, if you have just mild skin disease or mild muscle involvement, maybe we don't have to be so aggressive. Whereas if there's organ involvement, it may require more aggressive treatment. And you may see your doctor may start several medications right from the start, which may be hard. You just received a new diagnosis and now you're receiving multiple medications for your child. But the reason that some of them do that is because we've learned from research and studies and from our experience that using more treatments up front perhaps might limit the overall duration of treatment. So we may be able to get control quicker and really limit how long we're treating, and that can have benefits in the long run. You may also hear about different terms. So sometimes we talk about induction therapy versus maintenance therapy. And so I just wanted to give the definitions of what we mean by that. So when you're thinking about induction therapy, that's what we're using to get control of the disease and really limit that inflammation. Once we do that, and once the inflammation is better, then we're talking more about maintenance therapy. So we want to get them quiet, and then we want to keep them quiet for a certain period of time, and then we talk about starting to taper off therapy. So it's really a process for the treatment. So what can you expect from the initial treatment? So the pros is that it can be life-saving. So as Dr. Curran mentioned, it's rare that you get significant major organ involvement, but it can happen. So in some scenarios, treatment is life-saving, or it helps prevent long-term lung damage or prevents long-term muscle damage. So there can be quite significant pros to treatment. Clearly, we expect improvements in the muscle enzymes, the strength and function. So those muscle enzymes, or those blood tests that Dr. Curran was mentioning, those might improve more quickly than the strength and the function will. So you'll notice that your child, you might see some quick improvement, but it might not fully resolve. It might take a little time to fully resolve, and the strength and function can take a little bit longer to come back. But over time, you should also notice improvements in energy, again, getting back to those daily activities, and improvements in the skin manifestations. The cons of treatment, which we'll go through, are clearly side effects. So again, any treatment that we give, there's always the risk of side effects. And, the big one is always that infectious risk. And so again, just being very careful with that. I'm going to talk a little bit about some of the medications, but some of them might cause weight gain. Some of them might cause changes in appearances or mood changes. So again, just balancing those side effects. Some of the other cons to treatment are that they have to come to the doctor often. So the way that we monitor these patients and the way that we monitor the treatments to make sure we're doing that balance correctly is by seeing them very often, so that we can, back off treatment when it's appropriate or use more when it's appropriate. And then that also means somewhat frequent blood work, at least in the beginning, which hopefully over time that spreads out. But of course, when you have a young child, that adds another level of stress to the whole situation. So how do the treatments work? So I'm going to spend a little bit of time talking about these 4 treatments, as these are really kind of the mainstay in the initial treatment of JM. And so I'll go through each of them and just a little bit about what they do, and what the main side effects are. So I'm going to start with steroids. So steroids have been referred to by this term of frenemy, which I actually think is like the perfect term, because we truly love them and truly hate them all at the same time. Steroids are made naturally in your body. They're made by your adrenal glands, and this is going to be an important thing to think about later. I'm going to mention it again. But they work incredibly fast, and they're incredibly strong. And so they can really get control of that inflammation very quickly. And when you have someone who's been suffering for some time, who's very weak, who maybe has organ involvement, we really want to get control as quick as possible. And so the steroids can help us to do that. The problem is that they work very broadly, so they can also have a fair number of side effects, which I'm going to go through. And so trying to mitigate some of those side effects is something that we work through carefully. Steroids come in different forms that you may hear. So prednisone is in pills, prednisolone is a liquid, solumedrol is given through IV. It's usually given at higher doses. So there's different types of steroids that we use. And often we give steroids with a medication to help protect the stomach lining, because that is something that we worry about, especially in the higher doses. So if you Google prednisone or steroids to see what they do and what their adverse effects are, you'll get an enormous list. So again, I'm not going to read through it, but this image here just lists some of those side effects that you might see. Which ones will you most likely notice? So the most common thing that people see is that their kids are really hungry, which in some cases it's a nice, it's welcomed, because you might have a kid who hasn't felt well for a while, maybe has been losing weight. And so it's great to see them hungry and, looking more themselves again. But clearly over time that can become a problem if they're eating too much. And really with the higher doses, they can become very, very hungry. And that can lead to weight gain. You may also notice that if your child's on higher doses steroids initially, they may end up getting these chubby cheeks, which are called Cushingoid facies. And again, initially it might be cute little chubby cheeks, but over time, it might be uncomfortable to the patient, or they might feel a little bit distressed about how those cheeks look. You may also notice that they become moody, and that doesn't happen to everyone, but certain kids are a little bit more susceptible to it, where it kind of just makes them more cranky, more irritable. Sometimes they could be a little bit more sad or depressed. So just being mindful that that might be the steroids that's causing it. And it can also cause problems with sleeping, depending on what the dose is and at what time of day it's given. The other more common things that sometimes are noticed when you're on it for a little bit of an extended period of time, as most of our patients are, is that sometimes it can cause acne. Sometimes you can see some extra hair growth and also some stretch marks. Most of these things improve as time goes on, and they can, as we lower the dose, most of the time these things get better. The stretch marks, unfortunately, is something that can't be reversed, though, if it does happen. And then again, there's the risk of infection that we talk about. And so really just being cautious while on these medications. Usually if your child has a fever or something along those lines, you just have to check in with your rheumatologist or your primary doctor. In terms of long-term usage of steroids, that's when we get into the concerns about some of these other things like issues with growth, issues with the bones. You can get weakened bones like osteoporosis type of picture. You can get high blood pressures, high blood sugar. It can impact your eyes and cause glaucoma. So some of these things that you don't typically see in young children can happen with someone who's on prolonged steroids. And then rarely there's something called steroid myopathy. And I only bring it up is because it can sometimes be, we're treating your child for weakness with the steroids, and then that can potentially be adverse effect of it, whereas it makes them weaker. But that's a really rare effect, and it happens over time. So, but it is something that we keep an eye out for. Steroid withdrawal and adrenal suppression. So I just bring this up here because this is something that doctors will reinforce quite frequently. So when you do have your child on these chronic steroids, you have to be very careful about abruptly taking them away. I mentioned before that they're made in the adrenal glands, and so these steroids are critical to your normal function. So we all have steroids naturally in our body, and these steroids help us respond to stress. And if you've been taking chronic steroids for a long time, it actually suppresses your own body's ability to make that steroid. And so you have to be cautious with someone who's been on exogenous steroids for too long. When you have a severe stress, such as a major infection, trauma, surgery, your body has to, again, increase that steroid. And if you can't do it, it can cause illness. And these are just some of the manifestations that you might see. So usually it's not a problem as long as we taper them slowly. So the main point here is just never to abruptly stop them, and always talk with your rheumatologist about slowly tapering them off. And then the other main point is, even once you're off the steroids, just to be sure to notify anybody that your child has been on steroids in the last 6 months or a year or something along those lines. So we just talked about our love-hate relationship with steroids. And so steroids really are one of the keystones in the treatment of JM. So we're not at a point that we can avoid them altogether. We still really think that they have an important role, but we all recognize that we want to limit those long-term side effects. And so some of the ways that we can limit them is we do try to consolidate the dose. So sometimes when the child is sicker, the steroids might be given twice a day or 3 times a day. And so we consolidate them down to once in the morning. That can help. Usually they're given first thing in the morning with like breakfast. That also can help with some of the side effects that I mentioned. And then ultimately, it's really reducing the duration of those high dose steroids. And so again, comes back to that close monitoring, tapering. Sometimes we use those intravenous steroids that I had mentioned, because giving those more aggressively up front actually can limit how long you're on steroids. So again, it's not so much the steroid dose always, sometimes it's how long you're on those high dose of the oral steroids. So the IV steroids can help with that. And then it's really initiating some of these other medications that we call steroid sparing agents. And like I said, even though it's overwhelming when you first attend a doctor's visits to have them start so many medications, we often start one or more of these medications along with the prednisone from the beginning to really help the long-term course of the illness. And so, like I said, the ones I'm going to mention are the methotrexate, IVIG, and hydroxychloroquine, but these are some other ones that you might come across depending on your child's illness. So methotrexate. Methotrexate is also a very highly effective medication in JM, and it's been studied pretty broadly in the disease. And so the methotrexate it also works pretty broadly on the immune system to reduce that inflammation. If you look it up, you might see that it actually is a chemotherapy, but we use it very differently than people do when they're using it as a chemotherapy. So we use it in very low doses, whereas in cancer patients, it's used at very high doses, and it works very differently. So just not to be nervous if you look it up, we use it again in very different doses and for different purposes. When we use it, it can actually take about 4 to 8 weeks to really see the initial effects. And so that's why we start it with the steroids, so that the steroids can help bridge until that methotrexate kicks in. It's given weekly, and it can be given as pills or injection form. We often give it as the injection form in JM because sometimes there's a concern about absorption. And so if you give it by an injection, it might be more effective in treating the disease, but that might vary based on your provider. And often if it's given with folic acid to help reduce some of those side effects. The side effects that we see with methotrexate, the most common are that patients might feel a little bit tired or sort of just yucky after they take the medicine, either that day or the next day, or maybe for a couple of days after they take it. And so some patients end up not really liking it. Again, it's very variable. Some patients can tolerate higher doses and they're fine, and other patients are very sensitive to it. So it just depends on your child. Some patients might have some stomach issues where they don't really want to eat, or they feel a little nauseous the day after they take it. And sometimes we'll have to give medications to help mitigate that. And then again, any of these medications, we just have to be cautious with any kind of infections. And so again, if you have a child who's on this medicine and they have a fever, you let your doctor know. Sometimes we'll, modify the dose, or we'll talk about what to do with the dose if that were to happen. Less common things that we see are sometimes it can cause hair thinning, but not, again, it's not like you would think for a chemotherapy where the child's hair is all going to fall out. It's nothing like that, but it might cause a little bit of hair thinning. Some patients might experience mouth sores, and then there might be some lab abnormalities, particularly with the liver and the white blood cell counts. But all of those things can, there are ways to sort of modify the dose or try to manage those things. And there are risks to this medication in pregnancy and with alcohol use. So this certainly becomes more of an issue in, if in adults who take this medicine. But certainly it's something to keep in mind if you have someone who's a teenager or a young adult who's taking this medicine. We try to minimize those side effects with the injection form. So I mentioned that sometimes we use the injection form to help have a more effective dose, but it's also can help with some of that nausea and that decreased appetite if you're kind of bypassing the stomach. Sometimes giving it at bedtime can help also reduce some of the side effects. And again, maybe some dosing modifications can help with that. The third treatment I'm going to talk about is IVIG. So IVIG uses antibodies to help reduce inflammation. So it is derived from blood products. The nice part of this is that it doesn't increase the risk of infection. As I mentioned, some of those other medications do. It's most commonly given by the IV, but nowadays there is a sub-Q form, which some people are using. Usually we give it more frequently in the beginning, and then it ends up being given monthly. The most common side effects for the IVIG are that sometimes patients can have headaches, sometimes a little bit of nausea and abdominal pain. Sometimes they can get body aches or fevers when the medication is being administered. And so usually we modify that by giving pre-medications like Tylenol and Benadryl. Sometimes we have to run it slowly, so it's given over, maybe 10 to 12 hours. We give lots of IV fluids and hydration with it. And all those things can help mitigate some of these side effects. I've listed some of these less common side effects here, which are very rare, but just so that you're aware. And I see that we're getting a little bit late on time, so I'm going to just try to speed up a little bit. In terms of the hydroxychloroquine, that's the last medication I'm going to go through. The hydroxychloroquine is used by many providers, but not necessarily every provider. So there's no real, it's sort of provider dependent. So I don't want anyone to feel one way or the other if their provider suggests it or not. There may be some benefit in improving fatigue, rashes, joint pains, and it may have some steroid sparing effects, but it hasn't really been proven, which is why there's some variation in how people use it. It is given daily, and it's considered a very safe medication. We use it very commonly for other illnesses such as lupus and other autoimmune diseases that are similar to JM. So what happens if these first-line treatments don't work? So every child is unique, and so one size doesn't fit all. And so we often have to tailor the therapy to the unique symptoms of your child, depending on how severe the disease is, how they're responding to therapy. If they're having side effects that are just intolerable, we may have to change therapy. And so it's not uncommon to use some of those second and third line agents. So you shouldn't feel discouraged if your doctor wants to change therapy. It's really because they're trying to tailor it to your child. There's also adjunctive management that we have to think about. So you may have, your child may be on topical treatments. So if they have a lot of skin involvement, they may be using topical steroids or things like that. We talk a lot about sun protection, and so they really need to be careful as the sun can cause disease flares. So they have to wear sunscreen, and we tell them to wear it 365 days a year. So even when it's cloudy outside, to always have sunscreen on. They should eat a healthy diet. So steroids, like I said, make you very hungry and can cause weight gain. So if the kids are snacking, having them grab for healthier snacks will help mitigate that. Bone health is very important with the prolonged use of steroids. So using calcium and vitamin D can help. And then really exercise and physical therapy can be really critical. It might be hard to do that early on if the muscles are very inflamed, but as time goes on, slowly incorporating things that are safe is important. In terms of additional guidance, your child may have other appointments with other specialties, so just to be mindful of that. Medication adherence is an important thing that we talk a lot about and may become more difficult as the kids get older. So just kind of keeping an eye on that, as it does get difficult to have a chronic illness, and always having the psychosocial support there. I only have a couple more slides. So will it go away? So with the initiation of using steroids, as Dr. Curran mentioned, our outcomes for JM have gotten much, much better. And you can really achieve a state of inactive disease, whether it's on medication or remission off of medication. You should be prepared that it might change your lives. Again, we just talked about all the treatments that your child has to go through, all the medical appointments. There's missed days of school and work. You may need to do activity modifications depending on how weak your child is and if there's any concerns about their muscle strength or their bone health. And then again, just being careful with the sun. We have patients who go to the beach or pools, at 5 o'clock in the summer so that they avoid the sun. And then just one slide about the mental health. So again, there is concern for any reduced quality of life due to having a chronic illness, due to the side effects, due to changes in appearance. And so really early screening and becoming involved with that is very important from the beginning. Also being mindful of the impact on other family members. And then just knowing that we've looked into this and, even though it may be challenging for the children early on, we really have seen that by the time they become young adults, we do see that they have a lot of resiliency, which is amazing to see. And then lastly, just being mindful that, as pediatric providers, we're here sort of throughout the whole process of the illness and certainly to help with the transition into adulthood. So sorry for rushing at the end, but I'm gonna stop there. You can take any questions.
Well, we have a few moments for questions. Dr. Curran, Dr. Wahezi, thank you so much for two truly extraordinary presentations. I think this was an awful lot for everyone to take in, and we're grateful for the thoroughness and the ease in which much of which you said, if not everything which you said, was I think understood. We have some questions on chat. You can also just raise your hand if you have a quick question. We'll take questions for a couple of minutes before our time runs out. But also want to say that as you think about this, should you have any additional questions for Dr. Curran or Dr. Wahezi, please just email them to us at info@curejm.org. We'll make sure that we get the questions to the doctors and answers back to you if they come to you later tonight or over the next few days or whenever. So thank you very much for that. I think we have one question that I saw in chat. I think. Let me see if I can find it here. And a question from Meg, how do you measure steroid myopathy?
Right, that's a great question. And so again, fortunately, this is not something that we commonly see. It is something that really happens kind of in the long run. And so if you have a patient who you're treating and initially seems like they're getting better and their numbers are improving and they're starting to get stronger, but over time, even though the numbers have improved, they're still very weak. Then it might be something you might consider. So usually with the steroid myopathy, the muscle enzymes and the numbers look okay because there's less inflammation there, but the muscles still aren't functioning as well and they're still not as strong. So fortunately that doesn't happen, but if your child is on the steroids for a very long time, that might be something to consider.
Question from Danielle, do I have to worry about my son getting sick as well? My daughter was just diagnosed in December of 2020. She is 13 years old.
I can take that one. It's actually quite unusual for two siblings to have dermatomyositis. Most of the time, even when identical twins when you have an identical twin, one twin will have it and the other will not. So, and the reason that it is just not something that's easily passed like genetically is because it's a very complex genetic trait. It's not just one gene that causes myositis to happen. And you also need to have environmental triggers that not the same children, the same child might not be experiencing the same environmental triggers. So we don't do any special testing for siblings of kids who have dermatomyositis. Obviously, there are rare cases where it is present in more than one sibling, would be extremely rare. But the good news is that you as a parent, having gone through the diagnosis with one child, will know exactly what to look for if your other child were to experience symptoms. But it's certainly something that I would not worry about as a parent.
Thank you. From Tiffany, our 7-year-old daughter was just diagnosed. She also has type 1 diabetes. Other than steroids severely impacting her blood sugar, is there anything else we should know about type 1 and JDM?
That's another great question. So sometimes, unfortunately, one autoimmune disease can put you at risk for having other autoimmune diseases. So the main issue would really be the steroids. And I'm sure your doctors would take that into consideration in terms of balancing that treatment and really being cautious with the steroids and really looking towards those steroid sparing agents or other ways to treat the disease without having to use too much steroid. Other than that, that's the main issue that I would expect to be a concern.
Two more questions. A follow-up from Meg. Thank you. Burning cheeks inside and out on high-dose steroids, 120 milligrams a day for a 10-year-old. Is this a possible lipodystrophy symptom?
That's a really good question. I am not aware that there are any symptoms that can predict lipodystrophy or that it's associated with any physical symptoms. My guess is that it may be more due to the swelling of the fat cells in the cheeks. That can actually, some patients say that their cheeks are taut and painful at times. So it may be the development of those Cushingoid side effects. I can also look it up to see if it's been described at all. That's a good question.
Yeah, I would agree with that. I think the lipodystrophy is usually a sign of like low level inflammation that's been going on for quite some time, and sort of often the child presents that, that way, that maybe it wasn't seen for, the diagnosis was delayed or something along those lines. And not so much that with those symptoms, but I agree with Dr. Curran.
Well, thank you for these great questions. I think we have time for two more. And again, once again, should you have additional questions, please send them to us at info@curejm.org. From Angelique, you mentioned that there is new information regarding condition trajectory, long-term prognosis. Do myositis-specific antibodies help predict this as well? My daughter is 7 and has NXP2.
So we definitely see clustering of symptoms related to the different myositis-specific antibodies. And there was a paper published probably, I think, in 2017, where Dr. Ryder's group from the National Institutes of Health looked at a very large population of patients with different myositis antibodies. And I'm just looking at my notes over here. So for patients with NXP2 or MJ antibodies, it is thought that those patients have less skin disease, but more muscle disease. So they're more likely than patients with other types of antibodies to have cramps or changes in their voice, contractures in their joints, meaning that you can't straighten out your joints all the way because the muscles get shortened, and atrophy. There's also a risk, more of a risk for GI ulceration. And about 30% of the patients in that group developed calcinosis over time. There were higher rates of hospitalization for patients with MJ antibodies because it can present more severely with a lot of severe muscle disease. But some good news for that was also that this had a higher rate of being a monocyclic disease, meaning once the patient went into inactive disease and remission, and as the medications were pulled away, they may not actually ever flare. You can't take any of that as 100% will happen to your child. Those are just some trends that were seen in that particular study. But we are learning more and more as these antibodies are becoming easier to identify and more accurate testing.
Thank you, Dr. Curran. Let's take 2 more questions, and thank you for bearing with us. And I apologize for going a little long, but I think everybody's going to want to hear these questions and answers. Our daughter was diagnosed in November 2020. She had Gottron's papules. From dermato was referred to a rheumatologist, diagnosis with MRI, mild, topical steroid cream, prednisone daily, methotrexate weekly. She's 3.5 years old. What do you consider a long period of steroids, and what is a high dose? She started at 10 mg daily and going progressively. And based on your experience, do you suggest to get a second opinion? Great question about second opinions.
Right. So, so of course it's hard to know without knowing all the details of the case specifically and not having met your child. But I think, from what you've written, that is a common first approach to start with topical steroids, methotrexate. And again, even in someone who's young, because we know that JM often presents in younger school age kids, we do have to use these medications. And so all of that sounds pretty standard. In terms of how much to give and how long to give it, that really varies. In the past, people would often do 2 milligrams per kilogram per day and, very high doses for like months, and then they would slowly taper. And so we used to use a lot of steroids, and over time, we still unfortunately use them, but we do try to be mindful of it and try to taper them. And so without knowing, all the details, it's a little bit hard to say specifically if that's appropriate or not. But when it comes to second opinions, I always offer, if a patient doesn't feel comfortable for some reason, to consider a second opinion. If they feel, you have to trust what's happening with your child, knowing that in the beginning it's always stressful and feels scary. And, it may not be that the doctor's doing anything wrong, but just for your own comfort level, if nothing more, just to have a doctor say, oh, that's exactly what I would do.
Yes.
It can be helpful.
Final 2, our daughter is 14, diagnosed 2 weeks ago. She has never had skin issues. Is it common for someone with JDM to have no skin issues prior to diagnosis?
So I can answer this one. So it is possible to have autoimmune muscle disease without skin changes. So we call that juvenile polymyositis. So I guess I would have a few more questions about how the diagnosis of dermatomyositis was made without any skin disease at all, because by definition, you need to have skin disease in order to have the diagnosis of JDM. There are rare cases where, and instead we would call that patient polymyositis. And these are cases where we usually get muscle biopsies if there aren't classic skin findings. And generally, the muscle biopsy findings for polymyositis look different than the muscle biopsy findings for dermatomyositis in various ways. I have had a patient who had no skin rash, and we did the biopsy, and the biopsy looked exactly like you would expect for dermatomyositis, not polymyositis. So it is possible for that to happen. But most patients, by definition, to get the diagnosis of JDM, you need to have skin changes. Most generally, the Gottron's papules or heliotrope rash, or potentially some other rashes. I don't know, Dr. Wahezi, if you have any other thoughts about that.
No, I mean, I agree with that. I think, you know, there is a spectrum where some patients have more skin involvement and less muscle and, you know, varying degrees of it. But I do agree that if without the skin manifestations, you might not call it JDM, you might call it a different type of juvenile. They call it idiopathic inflammatory myositis, so just a broader term for it. And for all intents and purposes, some of the treatments may be very similar, but so it might just be terminology. But I would question, you know, you can ask just to confirm for yourself to understand.
And our final question for the evening regarding IVIG, was told that this isn't very effective unless you have myositis-specific antibodies. Would you agree? We've had our worst fatigue and pain week ever, despite our high steroids and CK and liver enzymes stable again. Sounds like IVIG could help.
So I wouldn't say that the use of the medications at all are dependent on myositis-specific antibodies. I don't think we know enough about those antibodies yet. I think the identification of them has been really groundbreaking for the world of juvenile myositis, because I think it is helpful to know what manifestations a patient might get and how to predict what their prognosis might be. Again, even as Dr. Curran said, it may not be perfect, but I think it is very helpful to have those antibodies, but I don't think we know enough about how those antibodies translate to treatments and which treatments work or not. That hasn't been studied. I think IVIG works very well. There are studies looking at IVIG and the use of dermatomyositis, and we've had great success with it. It can help a lot with the skin manifestations, so some people might use it more for that. But I've certainly used it for muscle manifestations too, and haven't made my decisions based on the antibodies.
Yeah, I would agree with that.
And I'll answer this final question from Kim. Kim, thank you very much. Yes, CureJM has a number of parent support groups. We have 16 chapters, 17 chapters across the country. There are also a couple of online JM support groups like JM Moms. And if you want to email me, james.minow, M-I-N-O-W, at curejm.org, I can put you in touch with our staff member and others who can help you with those connections.